Hey guys, welcome to Cozy Talks Live. I know I was running a few minutes late, so I cut the countdown by just a little bit. Hmm. Guys, I got to show you something really cool. So I made the kids chocolate chip cookies today for dessert because I just wanted to make chocolate chip cookies. And my youngest, he usually brings me like a decaf coffee for the show. And then tonight he decided I needed milk and cookies. So isn't that the sweetest thing? And I promise I'm going to try my best not to sit here eating on the show in front of you guys, but it's going to be really hard with these chocolate chip cookies sitting in front of me. Not to just like start nibbling. All right, let's get our greetings underway. Let's see who is here this evening. We got Scott coming in from West Virginia. He says it's warm for this week. Yeah, it was actually hitting 90 on the car thermometer outside today. It's insane. We got Martin on board. Martin, I got your question ready to go. We got Chrissy coming in from Auburn, Nebraska. Temperature this week 55 to 60. So you guys are having a nice little warm spell there as well. What's up, Jeff? Jeff, I'm glad you're here, and I hope you're going to stick around because there's a couple of insurance questions about prosthetic devices that your girl here does not know about. So hopefully you can help me out with that one. We got Tom here. Tom, I'm so glad you're here this evening, and I hope you're doing better. We've got Martin says we got 60-degree days in Loveland, Colorado this week. Enjoy it, my friend. Enjoy. We got Emily on board from Central PA with her ice brown sugar latte. She's always got the nice stuff, man. Dave's on board saying hello to Glenn. Glenn, are you in there? Come say hi to me. We got Chuck here from Wyoming. And Dave, I am so happy that you are going to be getting physical therapy with my dear friend Michelle. It's going to be amazing. We've got Mary coming in from Arizona, Tom coming in from Canada, from Ontario. I wonder if you're having any kind of a warm spell yourself, Tom. We've got Comadre on board. I'm going to give a shout out to the Mena girls this evening. Big hug to all four of you beautiful girls. We've got Stephen coming in from Michigan. Mark, there must not be a game on tonight that you are gracing us with your presence. Oh, it is a game night. Well, hopefully you'll still stick around. We got Glenn. There's my boy Glenn. He needs no introduction from Pennsylvania. Life is short. Eat the cookie. Yes, I know. I'm like trying not to like nibble in between the questions. We got Van Gregory. There's my grasshopper right there. We got Kim. I know he's so sweet. I got sweet kids. I really do. She's drinking her orange drink in Indiana. We got Dan coming in from Kansas City. Michelle coming in also from Michigan. We got Susan on board. Marshall heard cookie and he wants one. Oh, Marshall. We got to make you some doggy cookies. We got Cindy coming in from North Carolina drinking water. We got Daniel on board. We got Harsh. Pamela from upstate New York. Whew, I think I made it through everybody. And I think we got some folks here on the Instagram channel. We got Kathy on board. Cindy is also on board. Protege, I like that name. We got Scott Mahoney on board as well. So guys, welcome. All right. For those of you who are new watching the show this evening, wondering who is this cookie monster eating person on your screen, welcome. My name is Cozy Belloso. I'm a physical therapist here in Tampa, Florida. I've been a PT now for a little over 23 years, and my passion is working with the amputee and limb loss community. And we're going to dive right in because y'all did not disappoint this week. You gave me 2 pages worth of questions, and I still have a couple of questions left over from last week that I do want to get to because we ran out of time last week, and I kind of like it that way because it means y'all are sending me the questions, which is what you should be doing because this show is for you. We've got Sherry on board from Orlando drinking her Gatorade, and Rich from Texas. There's my Texan. We got Jerry in. Good to see you. 88 in Arizona today drinking caramel macchiato coffee. Y'all got some good drinks, man. Y'all need to send me some of these drinks. This is good stuff. All right, we're going to kick off with the title question because that was one from last week. Okay, there is a gentleman who had a traumatic pelvic injury. And of course, I can't find my notes, but I do remember that question very, very clearly. So this particular gentleman had, I believe it was a car accident and had a shattered pelvis, right? So a lot of damage, a lot of bone damage done to the pelvis, resulting in an above the knee amputation on one side. Unfortunately, because of all the damage done to the pelvic bone, there was a lot of nerve damage, right? Which resulted in basically his hip flexors are paralyzed from what it sounded like in the email, that there's no appreciable movement there. And he has been struggling to try to learn how to use a prosthetic device. Okay. So guys, for those of you who are above the knee amputees, you're probably sitting there going, crikey, man, it's already hard enough to figure out how to, manipulate a prosthetic knee when you do have muscles intact. And now this gentleman has a paralyzed muscle. So a couple of things to note about this particular case. And again, I worked for many years. I worked in a level 1 trauma center in Miami. So many times when our patients came in, I mean, they were quite literal train wrecks, right? You had fractures, you had spinal cord injuries, you had traumatic brain injury, you had burns, you had a lot of stuff going on in the same patient. And unfortunately also resulting in an amputation in many of these cases. So we just call it, polytrauma, which is what this gentleman experienced. Okay, so first things first is you need to identify the extent of the nerve damage. Okay, and this is usually done through what's called an EMG, electric myography, or nerve conduction studies. Okay, where they figure out, is the nerve working? To what extent is it working? Okay, because a lot of times, what looks like a muscle that is paralyzed, it's just a very, 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 very weakened muscle. Okay, but if there's just even a little bit of a nerve impulse going through there, it might only get picked up by an electromyography, by nerve conduction study. Okay, and to understand what is the extent of the damage, which nerves specifically are damaged and what can be done to work around that. Okay, and then after consulting with a neurosurgeon, there are, and I'm not up to date on these techniques myself. I actually need to kind of get myself up to date, but there are things as nerve transplants. There's some pretty amazing surgeries that are in the works right now, in research right now, and that's something a neurosurgeon can talk more about. But in terms of knowing what you have, and you guys have heard me talk a little bit more lately about finding root cause, like finding the root cause of a problem and really taking the time to do that, because in finding the root cause of the problem, then you can actually get an attainable solution, right? So in finding what is the root cause of this muscle paralysis, meaning where is that nerve damage coming from? Okay, so in the way the gentleman described how he's moving, I think that there is some movement there in the muscle, and there's some there. Okay, and this is where, again, the help of a physical therapist to kind of start teasing out that muscle contraction with the use of electrical stimulation and other techniques to try to see how much of that muscle we can get working. Okay, but let's go to the worst case scenario. Let's just say there is no nerve impulse going to that muscle. That muscle is dead kaput, the hip flexors. So those are the muscles that are going to move your leg forward. And many of you are probably sitting there going, well, gosh, that's kind of an important muscle you need to have. Yes, absolutely. But does it mean that all hope is lost? No, there's a couple of options. The first one that immediately pops to mind is using a straight leg prosthesis. Okay. So again, this gentleman detailed about how he was trying to use a prosthetic knee, and I applaud him for the effort. But if he has zero musculature there, it could be pretty tricky learning to use a prosthetic knee. However, he could learn how to use a straight pylon. Okay, so basically what that would mean is that he would just have the socket on his above the knee amputation, okay, and then just have a straight pylon down to the foot. Okay, if he had a knee, okay, and it could be that the process just decides, you know what, let's put a knee in there for cosmetic purposes. It could be a manual locking knee. Okay, so it's the kind of knee that when you stand up, you push a little button and it locks an extension. Okay, and that's most likely a good option for this particular gentleman, so that when he sits down, right, he can bend the knee and not have it just, sticking out in the air like that. Okay, and he would learn to walk using a circumducted gait. Okay, so it's the kind of gait that typically you don't want to see in your patients or amputees, but in the case of this gentleman, it would make him functional. Okay, so when you're walking with a circumducted gait, here's Bob, everybody say hi to Bob. Okay, he would walk and he would kind of swing his leg out. Okay, or he might do just a little bit. Yeah, no, he'd have to swing his leg out doing it this motion. Okay, is it ideal? No, it's not ideal. And would he potentially be more vulnerable to chronic overuse injury? Yes, because you're using a gait deviation to motor forward. But would it give him the ability to become a functional ambulator? Quite possibly. Quite possibly. And again, this is where your neighborhood friendly physical therapist can come into play. So if this man's only option for walking is by using a circumducted gait like that, then the therapist's job would be to make sure that everything else is nice and strong and tight to hopefully prevent a chronic overuse injury, right? And to continue to follow him. But it could allow him to become a functional ambulator, okay? So that's just a little something there, because I know he's not the only one who's had nerve damage. I know there's several of you out there that because of a motorcycle accident or car accident that you experienced, damage, nerve damage as a result that also resulted in your amputation. All right, we got Pastor David on board coming in. We got Robert here from Georgia. Eric coming in with his Sprite Zero. Emily says, I kind of dealt with this because of my spina bifida. I have a KAFO attached to my prosthesis, and the KAFO has knee locks. Right. So with spina bifida, it is a spinal cord injury that happens in utero when the baby is inside the mom's womb. Right. So it is a spinal cord injury, and there's depending on the individual, a varying degree of a muscular paresis, which is a weakness, or complete paralysis. So yeah. That's exactly it, Emily. And again, this is where the skill of a prosthetist and orthotist can also be very handy in figuring out, okay, how can we work around this muscle weakness, okay? But again, it all starts with what are we looking at, okay? What are the nerves that are damaged? What are the muscles that are damaged? Is there a surgical option to help with this, like a nerve transfer of some sort? And then if not, how do we proceed with prosthetic and orthotic care after that? All right, looking back on here on my Instagram, we've got a couple more people that Molala Shell, that's a very interesting handle. Obs, the cyborg DPT, joined on board, and we've got Jeff on board as well, guys. Welcome. If you're on Instagram, don't be shy, guys. I'd love to know who you are, where you're from, and what is in your mug. For whatever reason, my Instagram folks tend to be a little bit more shy than my Facebook and YouTube folks, but we're going to bring them out of their shell. Let's see. Steven says, I have a manual locking knee and I have it locked for when I walk with a walker or crutches. I still fall too much without some assistance. Emily says, before amputation, I walked with a swing through pattern. Right. Guys, there's a lot of ways of doing it. There's obviously the ideal way of walking, and if we can avoid using gait deviations, we want to do so. But again, if it means the difference between a person walking and not being able to walk, then we'll manage with the gait deviations and work around it, right? Stephen, in your case, again, if you're finding that you're falling too much, I got to jump on this soapbox for you, Stephen. My question would be is how can someone teach you to use that knee better so that you're not going to be at risk for falling? So again, go to the physical therapist, see if you can find one who can help you out with that. I got to sneak that in there. We got Robert Jones saying my prosthetic pro Malone. Well, yes, I've seen her on Instagram, has me walking straight again. And that's wonderful. That's wonderful. All right, here we go. We got a question here from Cindy. So Cindy says, I've been a left below the knee since July. So coming up on almost a year. You've got about 3/4 of a year, 9 months. I'm trying to practice with the leg several hours a day. I think I've had all the PT I will have. Didn't do much. Sorry to hear that. I want to practice steps and getting up from the floor, but he said not to do that because I've already fallen. Right now, I want to learn how to walk without a walker. Do you have suggestions? And there's more to her question I'm going to get to in just a moment. So Cindy, again, I don't know, just from the sound of it, it makes me wonder if the physical therapist you worked with, if they, had amputee specific training, right? Unfortunately, even though physical therapy is a very widespread, very well-known profession now, there's not a lot of us who specialize and work specifically with amputee care. And this is a huge deficit in our healthcare system. It's the primary reason I started the show 7 years ago, okay? But it sounds like the physical therapist perhaps did not know how to really teach you the proper gait training with your prosthesis. And yes, getting up and down off the floor, that is a skill that they need to consider teaching you. Majority of my patients, I teach that skill. There's a very small number of patients of mine that they are simply not going to be able to get up off the floor because they're very frail, or they simply don't have the strength, in which case I teach them other strategies on how to first of all, how hopefully not to fall in the first place, but then how to help themselves out. But for the majority of my patients, I do go through it. It's not fun. It's not pretty, how to get up off the floor sometimes with a prosthesis or without a prosthesis, but it is a skill that needs to be taught, and it should be taught by your physical therapist. Okay. So Cindy, first off, if you can continue to scout around in your area and see if you can find a physical therapist that has worked with amputees before in the past, or at the very least is willing to consult with your prosthetist, because that's where a physical therapist can really learn a lot of the things that they need to know to work with amputees. All right. She says, I found you online a few weeks ago. Enjoy your Wednesday night program so much. Thank you. I'm trying to learn everything I can. I can believe it. I know nothing about the liner and leg hygiene if I had not read it. Ooh. I'm still on my first leg, having difficulty getting it adjusted. It's not quite so painful. I'm considering getting a second opinion from another prosthetist. I won't be told about different knees and feet, so I need to know what to ask for. And I'm thinking microprocessor. Interesting, because you said you were a below the knee, so maybe that was a typo. You're an above the knee. I'm rated a 2-3. I have rheumatoid arthritis, which limits me, but I love to run and play with my grandkids, and I love yoga. I made a prosthetist with an appointment with a prosthet comes very highly recommended. I'm very excited. And when I told him I wasn't given a choice at the hospital, he was very upset. He's an above the knee amputee himself, so he'll be able to relate. Okay, so yay, good news here. Love what I'm hearing here, Cindy. And yes, and guys, we talked about this on the last show, and I believe it was also your question, Cindy. Getting a second opinion when you're like bat signal goes off, your radar goes off, that you're just like, I don't feel like I'm getting anywhere with this prosthetist or even this physical therapist. Socket is painful, which is a big no-no, and it's not improving. Like, I just don't feel like I'm getting anywhere, and you feel like, should I get a second opinion? If you're asking yourself that, the answer is yes, you should get a second opinion, okay? Second opinion is either going to tell you, yeah, you need to find a new prosthetist, or that second opinion is going to tell you, you know what, your prosthetist is on the right track. You just need to keep going back and keep trying. Okay. But Cindy, in this case, it really does sound like you need to find a new prosthetist, because if they're not giving you choices, if they're not giving you options, and you're still having pain in that socket and it's not being resolved, you don't got time for that. You don't have time for that. So I'm glad to hear that you've connected with somebody who was recommended by another amputee, because I think that's really honestly the best way to find clinicians in general. All right, looking over here in Instagram, we've got the Cyborg PT says, amputee PT from Fort Worth. Man, I love seeing a fellow PT on board. So thank you for coming on board. We got Jeff saying, Georgia, left below knee amputee, and I go to POA in Chattanooga, Tennessee. Man, that is one of the best clinics over there in that area. I love me Ronnie Dixon. He's a wonderful, wonderful human being. We've got the Grateful PT that joined in on board. We've got a lot more PTs going on in Instagram. So I am happy to see my brethren here. Let's see. Steven says, or move to the Tampa area. Hey guys, it's great over here. Gotta love the weather right now. All right, let's get to this next question. We got Christy. Christy says, I had a below the knee amputation 11.5 months ago, so almost the 1 year mark. Congratulations, Christy. You're almost there. I actually had a prosthesis cast and made my first socket 7 weeks after surgery. The socket fit, but it was never, ever painless. Man, there is something in the water, because I'm getting a lot of the painful socket questions, man. That's not cool. It hurt every day to wear. And in August, oh dear, I had bone detachment, opened me back up, attached it back to the bone. So I also then got a referral for a different prosthesis here in Tennessee. I wonder if it's Ronnie. You have to go to the referral, new prosthetic guy. He would go in a completely different direction. I clicked way better with him. It's probably Ronnie. Thank goodness for her. Good vibes. 4 weeks later, he's at the app that's on the phone, casted him with that. So you got the new socket done with the casting. Still having some issues with fluid pocket at the end of the bone. So we're trying to figure out if it's an infection and what is going on. Okay, a lot to unpack here. So let's take this, because what I'm sussing out from Christy's question is related to how her surgery was done. And she sent me a follow-up email just now to confirm what I suspected. Okay, so when a surgeon does an amputation, there's a couple of different ways that there are a few different ways that they can manage the soft tissue, meaning the muscles, right? In some cases, when the muscle is cut, the surgeon will attach it to another muscle on the opposite side. Okay. And that's to kind of give the muscles something to kind of pull on. And it's called a myoplasty. Okay. So they'll attach muscle to muscle. Okay. So usually that is done. My understanding is that is done when there is not a lot of great circulation there, right? So they have to attach it to another muscle because muscle itself, muscle belly, has a lot of great circulation. So if the surgeon is seeing, you know what, the circulation in this area ain't so great, and we want to make sure that these soft tissues get the best circulation they can, they'll attach it to another muscle. Another thing that a surgeon might decide to do is what's called a myodesis, okay? Where they attach the muscle directly to the bone. Okay. And that's basically how God intended for our muscles to be attached, directly to the bone. Our muscles are not attached to one another. They're attached to the bone through tendons, right? So when a person has a myodesis, meaning it's attached directly to the bone, okay, it's a bit more of a natural alignment of how that muscle's supposed to work. Okay. And again, usually you'll see that you have to have good circulation for that to happen, because again, that muscle attachment to the bone has to heal with good circulation. Okay. So what happens sometimes in our above the knee amputees, especially, okay, the surgeon will attach the two muscles together in the myoplasty across the end of the bone. Okay. It's called like a muscle sling. Okay. So what can happen is over time that can get irritated. So if the person is putting weight into their prosthesis incorrectly, okay, and they are weight bearing on the bottom, that muscle sling is going to start to snap, right, back and forth across the end of that femur. And if that sounds squeamish and uncomfortable and cringy, it is. Okay. And I can immediately tell, like if a patient comes to me and they say, you know, I'm putting my weight into the socket, and I feel like there's like this snapping motion, this snappy feeling at the end of my femur, at the end of my bone. And I'm sitting there going, okay. So obviously they have a myodesis, right? So they have that muscle belly sling at the end of the femur. Guys, is this making sense? I know I'm kind of like throwing everything in the kitchen sink at y'all. Can y'all give me a thumbs up, or can you guys tell me like, Kosi, yeah, you're really not explaining this very well. Try it again. Because I know this particular concept, I haven't explained it yet on the show. And sometimes it takes a couple times for me to get the explanation right in my head and out the door, right? Okay. So if the person has that muscle sling across the end of their femur, okay, and then they're putting weight into that femur incorrectly, okay, that's going to cause a lot of irritation. And sometimes when you have irritation, you get fluid collection, all right, especially if you have a bursa sitting under there, that bursa is going to get hot and bothered and inflamed. Okay. So all of these things can be going on at the bottom there. Okay. So first things first, again, identify the root cause, identify what is going on in that bone. Okay. Could it be that there's also a little bit of an infection brewing? Yeah. Okay. So all of these things are going to contribute to this diagram. You're right, Andrea, diagrams would help. Please hold. Y'all just can't laugh at my drawing because I can't draw. Okay. So here, we're going to do, oh gosh, I really can't draw. All right. So that's your femur. I know, I stink at drawing, guys. Y'all can laugh. It's okay. I really can't draw. Okay. So that's your femur, right? That's in your hip socket. Don't ask what's going on. And the femur was cut right there, right? So sometimes surgeons will take the muscles and attach them together around the end of the bone. Okay, that's what we call the myoplasty, right? And if you guys ever have your OR reports, you can find out what they did, which I think is kind of cool. Okay, versus when they attach it, if they attach the muscle directly to the bone, and then it's called a myodesis. Okay. So in the case of a myoplasty, right, it'll go around the end of the bone like that. And that's where you get that muscle sling right across the end of the bone. So guys, think about it. If your socket is not fitting properly and you're putting weight into that, it's that cut end of a bone pushing into that muscle sling, and then that muscle sling like snapping back and forth across the end of that bone. It's like, kind of gives me like the willies, right? It's just like a very uncomfortable sensation. And then if they have a bursa in there, so you guys remember the bursa, right? Those are like little fluid filled bags that you have all around your body and your joints to kind of cushion things around. If there's a bursa anywhere in there, that's going to get irritated and cause a bursitis. Okay. So this is going to cause fluid stimulation because that's the body's reaction, inflammation and fluid when there's an irritation in there. Okay. And yeah, it could lead to an infection as well. Okay. So again, first step is figuring out what is going on in there. Okay. And in her case, apparently the muscle had come loose and they fixed it, but apparently she's still having fluid collection in there. Okay. And then the second thing that they really need to look at is how is that prosthesis fitting? Okay. Because yes, a myoplasty, a muscle sling around the end of the bone, it's not the best. The myodesis is the best way. But even if a person has this kind of a surgical arrangement, guys, they can be very successful if their prosthesis is fitting correctly, meaning that they are not putting weight into the end of their femur. Jeff, if you're here, I'd love to hear you chime in on this one. Jeff is my prosthetist that comes on the show every once in a while. Okay. So again, if her socket has not been fitting properly and she's been putting weight and bottoming out into the end of that femur, we're going to keep getting that same problem. Right? How many of you guys have had that snapping sensation? Because I know I get it. I see it often enough in my clinic to be able to just recognize it. That you feel like you feel like there's something kind of like snapping on the inside across the end of that bone. How do you like my diagrams, Andrea? Not too bad, right? All right. Thank you, Tom. I appreciate that. Thank you, Mary. I appreciate that as well. Steve from New York says it's formed up, but it's in the 40s a couple of days. Martin says, why don't surgeons round off the femur or tibia for BKAs? They do. They bevel it. They try to soften up those edges. They do. But at the end of the day, it's still like a pole. I mean, think of it like my Sharpie pen, right? My Sharpie pen has a nice rounded end to it. But if I do this, I mean, it's going to hurt, right? It's going to cause pain into the palm of my hand if I keep doing that. Or if I take it and I keep pushing it down, it's going to hurt, right? It's still like a protruding device. Okay? Y'all are so sweet. Y'all are so full of it. My drawings stink, but that's so sweet of you for saying that. All right, here we go. So, again, with Christy, it's definitely figure out what's going on at the end of that bone. If it's a bursa, if it's an infection collection, if it's the muscle that has pulled away, figure out what's going on, and then figure out why the socket is causing that to be irritated. Because there's a correlation right there, guys. And again, which came first, chicken or egg, right? But this is where understanding, and then she wrote on here as well, someone, it was either Cindy or Christy, one of them wrote that they were not taught proper liner hygiene and proper skin hygiene. So again, big red flag there for me. Big red flag if a prosthetist is not teaching that and if the physical therapist isn't reinforcing it. But in the case, if you don't have a physical therapist, your prosthetist should be teaching you these things. Okay. And they should also be teaching you sock management. Okay. So in the case of Christy here, if she's been bottoming out in her socket, okay, then her prosthetist should have been teaching her how to put on the proper socks to keep her from bottoming out in that socket. Okay. Yeah. Okay. Here we go. Let's keep going. Oh, here's a cool one. Okay. So this one came in from my texting service, guys. Let me just put this up here because I always like to do this for my folks because this is becoming a really fantastic tool that I love to use. Okay. I have a texting service. Okay. And this is how you can sign up for it. You text Cozy Talks, all caps, one word to that number. Okay. I don't sell your numbers. I don't spam. I don't do any of that gobbledygook. Basically, when I go live on my show on Wednesday nights, I send out links so that you can just directly link to the show and it's a lot easier to find my show. Second thing is you can text me your questions directly. Okay. And I really love that because I can really grab these questions quickly. And that's the best, most effective way along with email. Okay. To reach me. So if you have not done so, please consider doing so. Let's see. We've got on Instagram, Roots of Spice. Is this only for above the knee or below the knee as well? Roots of Spice, this is for all amputees. All amputees. Above the knee, below the knee, hip dysarthritis, bilaterals, unilaterals, even my upper extremity folks, even though I don't get the chance to answer many of their questions. But this is for anybody who's in the amputee community, and this also includes clinicians, caregivers, and family members. So I think we got everybody covered, right? All right. Robert says the hygiene thing was the first thing I was taught. Sock management took me a bit to figure out. And yeah, guys, it truly is. And I really become more vocal about saying this is probably one of the most frustrating parts when you're first learning how to use the prosthesis. Not so much the walking part, but the managing your limb volume, especially if you're experiencing dramatic changes, which most of you will when you start using that prosthesis. It is very frustrating, especially if you don't have someone telling you, this is how it's supposed to, this is normal. Okay. Usually the frustration comes from the person thinking, what am I doing wrong? And it's like, nope, you're not doing anything wrong. Unfortunately, that limb is going to shrink like gangbusters, right? And then you need to continue to add socks until eventually it will plateau. It will plateau. All right. We got Martin's question. Martin says, I'm having a problem with my shin bone having too much pressure causing pain. It seems like 70% of the weight is at the bottom of my socket. No bueno. Making it where I can't wear my prosthesis for more than an hour at a time. Are there socks or other solutions to distribute the weight more at the top of my socket? Yes. And Martin says, and he's chiming, he says, would this be a good segue into the weight distribution or pressure distribution for socks? Yes, sir. And let me see if I can, give me 1 second. I'm going to get my toy box over here. All right. Socks. Let's talk socks, guys. All right. So we're going to give you the quick and dirty. These socks have different colors on them, and most sock manufacturers will do the same. They will color code. This one does not, because this one was cut here. But this one you can see has a yellow lining and the number 3 very conveniently located on there. And this one has a green lining and the number 5. Okay. This one I can just tell by feeling it, it's a 1-ply. Okay. So when we talk about amputee socks, we're talking about them in terms of their ply or their thickness. Okay. So a 1-ply is exactly that. It's just one layer. It's pretty thin. You can just see it's relatively thin. A 3-ply is the equivalent of 3 of these. So it's a thicker sock, okay? And you can just see it's already a thicker sock. 5-ply, you guessed it, it's the equivalent of 5 of these, right? A lot thicker sock, okay? So as your limb starts to shrink, okay, and you become more loose in that socket, you need to add ply as you go along, okay? It's part science, part art, okay? So again, when you first receive your socket, whether you're below the knee or an above the knee, your prosthetist and your physical therapist should be telling you how your socket should fit. Okay. Usually we do this with the trim lines. Okay. So like in the below the knee amputee, we'll tell the person, depending on the kind of socket they have, your patella, your kneecap should be sitting right here. Okay. In the above the knee amputee, we will be telling you, okay, when you put your leg in, right, especially if you have a suction, you're supposed to see the end of your limb through the little hole in the suction, or your trim lines should be fitting somewhere up in the area of the groin, right? So your prosthetist and your physical therapist are going to tell you landmarks to look for to know if your socket is in the right place. Okay. And then it should feel snug. It should feel like it's a very snug hug, not strangling tight. And you shouldn't have any movement or rotation in there. It should feel like a snug hug. Okay. So when you start to notice, wait a second, this is starting to loosen up, then you need to add socks. And usually I tell my patients add 1 ply at a time, especially in the beginning when you're still trying to figure out which way is up, okay? Because if you get too sock greedy, right, and you put too many socks on, you're going to elevate yourself out of that socket and it's not going to have the right fit. Okay, you need to be in the same place in that socket every time. Okay, so let's see. So yeah, Martin, first of all, you should not be wearing bait. Wearing bait? Really? Bearing weight? What did my son put in that milk? You should not be bearing weight in the end of your socket. Okay, unless you are a Symes amputation, meaning only your foot was removed, or unless you are a knee disarticulation, or if you have an Erdl amputation as a below the knee. Okay. And believe me, if you have one, you know you have one. Okay. So if you're having to ask yourself, am I one of these? Then you're not. Okay. But your typical below the knee amputation and above the knee amputation, you are not supposed to be putting weight into the end of that bone. Remember what I showed with my handy dandy little drawing right here? Right? We do not want to put weight on the end of that bone. The weight is being distributed among other soft tissues. And depending on if you're an AK or a BK, it might actually be distributed somewhere else on your skeleton, not the end of your bone, not the end of your bone. Okay. So if you are bottoming out, it means you need to add socks. Okay. Now, there does come a time, like I'm seeing with Steve here, that he's saying he has 18 to 19 ply. Holy smokes, Steve. Okay. You're just wearing a big puffy blanket at that point. All right. There does come a time where you have too many socks. And what happens is you start to put on so many socks that by the time you fill up the volume in your socket, you're also pretty much elevated out of that socket. Okay. It's kind of one of those things, right? And then you also start to lose the connection or the sense of proprioception with that socket, okay? And everything kind of goes kablooey with the balance and all that kind of stuff, right? So, we talk about when is it time to start with a new socket? When you have about 8 to 15 ply and when you start losing the connection to the socket. So Steve says, how will I know with line in my socks up with a mirror before I go from 18 to 19 every day? Robert says, I was taught to lift my leg and shake. If it moves on my knee, add a sock until it does not move. Okay, that's interesting. To me, it's more about when you're weight bearing. When you're weight bearing, because everything changes. So if you're shaking your leg up high like this, Robert, then you might actually have a little bit of movement. Okay. But then when you stand up and gravity takes effect and the soft tissue fills into that socket, that's more of what's important, I think, to determine whether or not you have enough socks on. Steve, I'm sure you meant to write a different word. And Donnie says, and then when to replace them as they wear out. Yes. So one thing to notice about these socks, guys, and I tell people, don't focus so much on the number, focus on the feel of the socket, because as these stretch out, right, it's not going to be 1 ply anymore, right? So if you're just used to automatically putting on the same amount of socks every day, you might find that it doesn't really fit as much anymore. And then the other thing is technically, this is a 3 ply, which technically means it's the equivalent of 3 of these. But I can tell you right now, just by feeling it, this feels more like 2.5 of these. Okay. So, use the number to kind of keep track of how you're progressing, but it's more about the feel. How does it feel? Okay. When you have that socket on. And that's something that it takes time to learn. Okay. A ver, ¿qué más? Steve says, I put weight on mine all the time. I like to stand all the time while I'm doing dishes or standing around. Steve, there's a difference between putting weight into your prosthesis and weight bearing at the end of your bone. There is a difference, okay? Should you be putting weight into your prosthesis? Yes, absolutely. You should be able to put your full weight into your prosthesis. However, you should not feel pressure pushing up at the end of your bone. Does that make sense, Steve? Okay. And that's a concept that sometimes it takes a minute to learn that concept. And actually, guys, you'd be surprised. There's a lot of doctors out there that they don't know that concept. right? That their patients will come to them saying, oh, I'm hitting the bottom of my socket, and the doctor won't know that that's not the way it's supposed to be, okay? So again, there's a difference between weight bearing into your socket and weight going up against the end of that bone. Yes? Difference. Okay. And actually, in my treatments, I'm constantly encouraging my patients to put weight into their socket. We want that because then that means that your brain will get used to putting the weight into that leg and will use that leg more efficiently. Martin says, so to even a distribution, I cut a sock in half to make the top part grab more. So I make my socks 1 ply at the bottom and 3 ply at the top. I must have a different profile. No, Martin, and actually that's what I consider to be like, sock management 2.0, right? So to my beginner patients, I don't go into that. Usually I go into the standard, okay, let's figure out the sock volume one at a time. But yeah, on occasion, I definitely have some folks that they just need the bottom part of their socket filled out more and the top part is good. So as you can see with this sock, we cut it off and we just fill up the bottom part. But again, that's what I call sock management 2.0. That's after you kind of really understand how your socket should feel and you go, okay, you know what? I'm filling it more up top than I am at bottom. So let me slice a sock and let's start playing around with it that way. I also find like with the seal-in systems, the seal-in suction systems, with my AKs, I sometimes have to do that. We have to cut things and put one part above the seal-in and one part below. And again, sock management 2.0. But no, Martin, that happens, quite often. Let's see. Michael says, I've been getting new sockets at 5 ply because of how far over the ischial containment has to be and how much the socket doesn't feel shaped right anymore. And Michael, you're not alone in that. What I've noticed, and this is not research, this is just me, 25 years of working in the industry, I've noticed that the more active people are, the less socks they tolerate. And I think a part of it is because if you're more active, it probably means you're also more in tune with the proprioception and the sense of where your body is in space. So if you're having to add on more socks, you lose that sense of proprioception. So I have some people that they cannot tolerate more than 1 or 2 ply in their socket, and it drives them bonkers. Like they need to have a very close fitting socket. I don't blame them. And then there's some people that I'm like, oh my gosh, you're wearing 15 ply and how are you managing it? Right? Michael says, so like right now, I recently got home from an amputee group meeting and my prosthetic feels like it's just dangling and I'm about to be cast for my next one and I'm only wearing 3 ply later in the day. Annoying and painful. Yeah. Yeah. And especially guys, those of you who are still in the first 1.5 to 2 years out of your amputation, this is unfortunately a normal part of it. That volume management is something that's ongoing. And I'm actually going to be releasing in April a series of videos specifically on limb volume management that I created along with Click Medical. So keep your eyes out for that. Martin says, I basically create a custom sock for myself so I can walk on it for more than 1 hour. Yeah, go for it. Let's see. We got Hadaya on board. We've got Ashley Oakley on board as well. We've got Everyday Eileen and Traverse as well as joining in. Welcome, guys, from the Instagram channel. Appreciate you guys being here. Okay, let's see. Oh, no, Michael, you are so not alone with dealing with socks. Guys, let's show Michael how many of you, whether you are currently having issues managing your volume with your socks or you very much remember what it was like when you first started out as an amputee. Put it in the comment section. Put like the word socks in the comment section if you feel Michael's pain right now. I'm like, I'm not an amputee and Michael, I feel your pain. Like seriously, this is something that, every single one of my patients, unless they're an osseointegration patient, okay, having to come in and deal with limb volume management in the socket. And it's annoying. It's annoying for me because like I'm really getting there. I'm grooving with my patient and, we're finally getting this exercise. We're grooving, and all of a sudden my patient's like, I'm bottoming out. And I'm like, oh, for crying out loud. Okay, sit down, take your socket off, put the socks on. Let's get going. 5 minutes later, I'm bottoming out again. Oh my goodness. Like, guys, no joke. I posted a video the other day about my patient. Oh, it's a great video. You guys should go watch it on Instagram. So lovely reel. And I kind of just did a montage of all the stuff that we did during his treatment before my camera ran out of battery, but I had more. But basically, he was hoofing it, right? We were working hard during treatment. And I had him for an hour and 15 minutes, no joke. He had to sit down and put more socks on 4 times. 4 times. And he had just gotten a new socket 2 days prior. So he had already outgrown his first socket. Not really, he had outshrunk his first socket, right? He came to me 2 days after getting a nice shiny new check socket. Okay, came in wearing 2-ply. An hour and 15 minutes later, he was wearing a lot more ply. 4 times he had to sit down to change his socks. Okay, and that's because we had him, like, if you look at that Instagram reel, I mean, he was working hard. Okay, so he was just being extremely active, which was contributing to that limb volume fluctuation. Okay, so Rolo says seal in or suction, what's the difference? So seal in helps you with suction. It creates a negative pressure in the socket. So a suction is a form of suspension system. Okay, so it's how the prosthesis is held on, to the residual limb. And we've done shows on suspension. There's a lot to unpack there. If you go to my YouTube channel, you'll see, who did I do that show with? I believe I did that show with Ronnie Dixon, and I did another show with Click Medical on suspension systems. So when you get the chance, go back to my YouTube channel and find that video, okay? But basically, there's several different ways to suspend the socket onto the residual limb. With the suction, it's basically creating a negative pressure. So you know when you have like the Chinese finger puppets and your finger just kind of, you put your 2 fingers in and your finger gets stuck? That's kind of sort of how it works. You put your residual limb in, and air will go out. And as you put your residual limb in, air is pushed out through a one-way valve. Okay, so it creates a negative pressure. So it sucks it in there. Suction, right? So when you have a seal-in liner, some of these liners, and I don't happen to have one, you have a liner and then it has like a little rubber ring around it, like a ribbed rubber ring. And that just kind of helps like get that suction in there. It helps get that negative pressure and that seal in. That's why it's called a seal in. It just kind of helps seal you in. And some suction devices, you also have to have an external sleeve. So a sleeve that goes over the outside part of your socket to close that system as well. So there's lots of different ways that can happen. Yes, Donnie, you're absolutely right. So the thickness of the liner is also going to contribute to it. So, I mean, if you're looking at this particular liner, and guys, I don't know the different thicknesses of liners. I'm not that fancy. Okay, but you know, you're looking at this liner right here is your standard silicone liner that I'm looking at. And I would say it's the equivalent of a 5-ply sock, 3 to 5-ply sock. Okay. So when my patients are telling me how many socks they're using, I'm kind of also in my head counting the liner as a part of it. Robert says, finally, during my 2nd year as an amputee, my stump is stabilizing and I'm able to be fit for a new socket. Yeah, there is hope, guys. There is hope. There's a stable limb and there's a mature limb. So with a mature limb, you know, your limb has kind of finished with all the soft tissue remodeling and everything like that, but it may not necessarily be stable. Okay. So if you reach that 2-year mark, all of the remodeling from the soft tissue injury from the actual amputation should kind of be done at that point, right? What's going to happen is what's going to determine whether or not you continue to fluctuate is your health status and your nutrition. Okay. So if you have still underlying pathology going on that's not under control, sorry guys. Okay. So if you're still dealing with issues with your blood pressure, your diabetes, your autoimmune disease, your vascular issues, and those have not been under control, then you're still going to have a lot of issues with your volume management. Okay. But again, I got a whole set of videos coming out on that. Michael, in terms of how to figure out how to shape a sock, again, this is something your prosthetist and your physical therapist need to be helping you with. So I would strongly encourage, especially if you're still struggling, I'm dropping my socks here, please go to your prosthetist and just say to them, look, I'm cutting up a couple of these socks and I just want to know if I'm doing this right. And prosthetists are wonderful. They have a wonderful bag of tricks on how to get sockets to fit properly. Okay. So truly, this is something that your prosthetist should be helping you out with, and also your physical therapist if you're being seen by one. Hopefully you are. Pam says, socks wearing 15 ply today. Richard's got 1 to 2. Janie says usually 4 to 5. Benjamin's just like, sock. Robert says, socks was my biggest pain to learn. Rolo says, yep, socks in the beginning, way weird. Scott says, I can never get it right, too tight or too loose. Christy says, socks 10 ply. So a lot of people here echoing in that socks, definitely not so much fun in the beginning to learn about. Donnie also correctly stating that certain medications can affect leg volume. Abso-freaking-lutely. Lots of medications out there that will cause water retention. Okay, or the opposite, a diuretic, right? So your volume's going to go up and down and up and down. Okay, so it's really having a knowledge of what's going on with your body to get this under control and then to manage your limb volume. Okay, yeah, it is, Michael, but I promise you, please go see your prosthetist. Okay, let them help you. A lot of times I see sometimes with my folks that they try to solve the problem themselves so much and they can't see the forest because of the trees. So that's why we, the clinicians, are here to help you with this. So let your clinician help you with it. It could be that you're just kind of viewing one thing the wrong way and it's just a quick little fix, okay? Let's see. Okay, let's get a look. Let me look at one of these other questions that was sent in. Oh, this is kind of following up on Earl's question. So Earl said, all the talk about how many ply of sock people wear, what type of suspension do they have, and does it apply to suction systems as well? Just wondering, as I have suction. Yes. So people with the suction system can also have to use socks as well. Sometimes, you know, if you have an elevated vacuum, okay, that's supposed to help manage the limb volume better. So it's supposed to cause less fluctuations in limb volume, okay? But no, people who wear suction might still have to use socks and manage their sock ply as well. Okay. Tom says, I remember, Michael, what it was like in the beginning. I was putting socks on 4 or 5 times an hour. Okay. It was crazy. And now I'm in a seal-in socket, no socks needed now. And I've been an amputee now for 20 years. Okay. And again, Michael, as you progress as an amputee, your prosthetic needs and componentry are also going to progress with you. So it could be perhaps you are in a pin lock system right now. And as your limb starts to mature and it becomes a little bit more stable in the volume, maybe they'll switch you over to a suction system. So again, these are questions that you need to be asking your prosthetist, like where, you know, how is your prosthetic componentry going to grow with you? Okay. Yes, Earl, they do. Sometimes you do have to use socks with a suction suspension system. Yes. We got Adaptive Dad joining on board as well with our Instagram. We've got Tudoso Bream Amputados. So I think that's one of my Brazilian friends joining in on board. That'll be kind of cool. We got Everyday Eileen as well on the Instagram channel. Okay. Let's keep going because I want to make sure I hit all the questions tonight. Eric asks, how often does insurance allow the socket and supplies replacement? Guys, when it comes to insurance, PT or prosthesis, prosthetic componentry, I stink. I do know a couple of the basics. So for example, your liners typically are replaced 1 to 2 times a year, ideally at least 2 times a year. Sometimes with the insurance companies only do it once. Socks, I don't find that there's usually any problem with getting socks replaced. In terms of knees and feet, again, everything just depends on the insurance you have. I hear an average of 3 to 5 years for prosthetic feet and prosthetic knees. Some people have it more, some people have it less. When it comes to the socket, again, everybody is different. Some people need several socket replacements in those first 2 years, in which case the insurance should be covering them, and it should be written as letter of medical necessity. So again, this is up to your prosthetist and your surgeon, and sometimes even your physical therapist, to help contribute to whatever documentation needs to be done to justify your needs for this prosthetic componentry. We got GI Jane here asking, hang on, whew, I'm dry. All right. So Robert says, luckily I have VA through the military, and they have me getting new socks and checks every 6 months. Yeah. GI Jane says, I am between Oprah. Excuse me. GI Jane says she's between stage 1 and stage 2 of the Oprah osseointegration procedures. What precautions are there for sockets? Note, my doctor is being deployed for 9 months. Okay, so if you're being delayed in stage 2 because your surgeon is just not going to be in the country, totally understandable. And actually, when we had Dr. Forsberg here a couple of weeks ago, phenomenal osseointegration orthopedic surgeon. He stated, sometimes life happens. Some of his patients might have an extended period. Thank you, Tom. Might have an extended period between stage 1 and stage 2 because they are busy with their life and they can't make it in for that second surgery. In your case, it's because of your doctor. So the cool thing about the Oprah procedure is, yes, you have 2 stages, right? But in between stage 1 and stage 2, you do have the option. Thank you guys. You guys are all saying bless you. You do have the option of using a socket. Okay. However, your doctor needs to sign off on that. Okay. Your doctor has to give you the blessing to go back to your prosthetist to be fit for a socket. Okay. So even if your doctor is leaving for 9 months, is being deployed for 9 months, okay, he should let you know whether or not you are going to be allowed to use a socket. Okay. So he has to be the one to say, go for it. Okay. Once your doctor says, yes, go forth and get your socket. Okay. Your prosthetist, okay, needs to have been kind of trained on this, but they really need to be careful to keep the weight off the bottom. Now that's been kind of the theme, right, of this show tonight, about keeping the weight off the bottom of the bone, okay, whether it's the femur or the tibia and the below the knee, okay, but especially so if you are in the middle of stage 1 and stage 2 with Oprah. So your prosthetist just has to be super duper duper on the ball about making sure that you are not bottoming out in that socket. Yes. Okay. And Glenn, guys, if you didn't watch that show a couple of weeks ago with Dr. Forsberg and with Glenn. So Glenn he was on here earlier tonight. I don't know if he's still on here. Glenn is a high school teacher and a football coach and an above the knee amputee. Okay. And in his case, if I remember correctly, he had to use a socket between stage 1 and stage 2. The stage 2 was delayed because of COVID. So he had his surgeries done in the middle of the COVID madness, right? So he was delayed between stage 1 and stage 2, and he needed to get back to being a high school teacher and a football coach and being up and about. So he did use a socket in between the 2 stages. And again, his prosthetist had to really make sure and be on the game about making sure it didn't have any weight bearing at the end of it right there. Okay. So Adaptive Dad says, I use Limb Logic elevated vacuum and it really helps as it relates to sock management. Thank you, Adaptive Dad. So yeah, going back to our elevated vacuum, and guys, I probably should do an updated show on suspension systems. It's been a minute since I've done that. But the whole point of elevated vacuum is it's taking the suction system and to an nth degree. So it's a mechanical and sometimes a computerized pump that just sucks the air out of that socket, right? So it basically causes your residual limb to kind of fill up the space in that socket, and it promotes circulation and lymphedema and all that kind of wonderful stuff. So theoretically, your elevated vacuum should also help you manage your limb volume. It should be more stable during the day. Okay. And it also, people will say it helps them feel more connected to their socket overall. So Glenn says, of course I'm still here. Yes, I was in a socket between surgeries. And Glenn, I'm sure you can echo for me that the big thing was making sure there was no weight bearing at the end of your residual limb. Robert says, just so you all know, I have the best prosthetist. Shout out to Miss Malone Otwell. Well, shout out to her because we always love to hear about a good prosthetist. So Robert, you got to tell her to come join the show and come watch the show. All right, guys. Ooh, we answered a lot. Wait, let me make sure. Hang on. Ooh, here was a good one. Okay, one last one, guys. And this one's actually a question for you guys. This person sent in a text message and said, hello, this isn't so much a question, but something I think would find interesting to have on your show. Being an amputee, one of the most exciting moments is getting a new set of legs. I think it'd be interesting to hear from people talk about why they chose a system. They chose what they love about it, how they wish it was different. I'm a bilateral lower limb amputee and getting my new legs on Friday. Okay, so guys, pick one thing, because I know we're running out of time. And Glenn says, you're right, no contact with the bottom of the limb. Pick one thing about your prosthesis, whether it's the foot, the knee, the suspension system, the osseointegration. Pick one thing about your prosthesis that you're just like, oh my gosh, this rocks, and this is why I chose this. Go. I'm going to have a bite of my cookie because I've been a really good girl, and I haven't eaten any of this cookie all night long. I've had these 2 cookies staring at me in the face, homemade chocolate chip cookies. So I'm going to have a bite of my cookie while you guys write in, okay? And I want you to tell me one component about your prosthetic setup and tell me what is that you love about it and why you chose it. So good. Okay, let me swallow so I'm not speaking with my mouth full. So Adaptive Dad says, I have an app that I can set the upper and lower limits of the elevated vacuum. Okay. Harsh says the socket and the foot. So what about the foot is it that you like, Harsh? Why did you choose that particular foot? Sherry says she's in a pin system and she likes it because it's easy and fast to get the socket on. Glenn says Oprah system, of course. No more sockets. We've got Donnie saying the torque flex. I'm guessing that's a foot. Benjamin says my hydraulic feet when I get them on Friday. Okay. Earl says the knee by Alex. Good knee. It's polycentric. I believe the Alex one it's at the polycentric microprocessor knee, Earl. Robert says the bow on my foot is giving me a great spring step. Martin says my prosthetic foot stays flat and I can move my foot forward and backwards, left and right because it's got spring suspension in the ankle. Chuck says he loves his Martin Bionic socket because it fits really well and he can sit easily. Tom says, OI, no socket. Notice a common thread here among our OI folks. I'm like, yeah, I'm not having to deal with a socket. Pretty sweet. Tom says he loves his blade for running, and I know that for a fact. Scott says, my design on the socket, since I'm stuck with whatever's available for a big man, sat foot and all. I remember you had a cool design on your socket, Scott. Benjamin says, I'm also excited about my magnet suspension system, which seems pretty new to me. I've never heard anyone talk about it. I've heard whispers. I haven't seen one yet. Well, do I have that? I'm going to have to look that one up. Hold that thought. Emily says, limited use so far, but I'm glad they were able to attach a KFO attached to the socket. Harsh says it's like riding a Cadillac, so he's got a cushy ride on that foot. Charlie says, my Grateful Dead lamination because I'm a deadhead. Rock on, Charlie. Pastor David says, elevated vacuum, automatic vacuum, no more connected, sorry guys, end of my night. More connected to the socket and the residual limb stays on. Donnie says, no, it's an admission above the foot that allows me to twist a bit. Okay, so it's a torsion. It's a torsion adapter, and it'll absorb some of the shock in each step. So a torsion and a shock absorber. Yes, those are kind of really nifty. It's a little accessory that's added onto the foot, but man, chef's kiss, it can really give you that movement. Let's see. Benjamin says Maglock 2.0. Cindy says, I've not chosen anything and there's nothing like about this first leg. So Cindy, hopefully you're getting some input here. And then if the best advice I can give you right now, Cindy, is talk to your prosthetist. Cindy, this is going to be for Cindy and anybody else who's out there choosing new componentry or a new leg for the first time. Tell your prosthetist what it is that you want to be able to do with this prosthesis. Okay, we all want to leap tall buildings with a single bound, but if you want to run around with your grandkids, if you are someone who is outdoors a lot, if you are someone who is sitting at a desk job all day, if you are someone who is walking around the mall, because that's what you like to do, you like to walk the mall, right? Those morning walkers. Tell your prosthetist what it is that your life is like, okay? And then ask them, why are they choosing a particular foot or knee for you? What is it about the function of that foot or knee, okay, that they think you are a good candidate for it? That's the conversation I want you to have with your prosthetist. And we're going to take it a step further. I'm going to give you all a homework assignment if you haven't already done so. Go to my website, cosytalks.com, okay? And I've been slacking off because I haven't written blogs lately, but the blogs that I do have up there explain the different types of feet and the questions you need to be asking. So when we're done here, y'all are going to go click on cosytalks.com, go take a look at those blogs and the cheat sheets that you can download and print out and take with you to the prosthetist office. Yes? Okay. Steve says, I have my pin system and I think I'll stick with that because when I see about everything else, the pin system is the easiest. Let things go wrong. Okay. Scott says, WVU design, but my Revo fit should be here anytime. That would be really good. Dan says, I have the lanyard strap and it works good for me. I would love to have the Oprah system, but it scares me, so I'm not going to jump into that right away. I'm just 2 years, AKA. Again, not a decision to be made, to be taken lightly, Dan. I agree with you. Michael says, my sockets are so uncomfortable sitting because of how much the ischial containment is pushed up the seat all up in my business. Yes. And definitely if you're in a true ischial containment socket as an AK, those trim lines are, they are up in your business. So Michael, again, talk to your prosthetist, communicate with your prosthetist and see what they can do, if there's anything that they can do to make adjustments. Steve says, I think I'll stick with the pin socket because less things go wrong. Yeah, simple. Kosi, can you make a setting for your live chat where we can upload a photo to share socket techniques or socket? No, at this point in time, it doesn't allow me to do that, Martin, although that would be kind of a cool feature to do that. But no, I mean, the technology I'm using, the software I'm using right now to do the streaming, it's pretty good. Now, if there's ever a time where you guys want to send me pictures of your socket or socks or whatever, and you give me permission, I can put it on the show and I can, put it up the same way I can put up like this picture of the osseointegration, microscopic view of osseointegration. So I can do that. And I've never thought to kind of put that out there, but we can probably do that. Okay. So Michael says, I'm talking to and going to be trying a new prosthetist for my current casting for my next prosthetic. And Michael, I truly wish you the best of luck. And hopefully you'll keep coming back to the show to keep me posted on how you are doing with that. Let's see. Jeff says the Davis foot because it walks amazingly. Adaptive said the Rush 87 foot, the feedback it gives me works well for my weight. And we got Kurt jumping on board as well. All right, guys, I am talked out and I'm not going to lie. These 2 chocolate chip cookies that I made are staring at me in the face saying, eat me, eat me. So I'm going to go put on my stretchy pants. I'm going to have my milk and cookies and call it a night. But guys, a lot of wonderful discussion here this evening. And truly, I thank you for contributing your questions, contributing your input and your advice to those people on this show as well. As always, guys, thank you for letting me be a part of your lives this evening. If you could do me a favor, guys, again, I am constantly trying to spread the reach of this show. If you feel comfortable, I would love it if you could either share this post, this show to your support groups or to your own pages. It would be greatly appreciated. Please don't forget, follow me on Instagram, subscribe to my YouTube channel, and hit subscribe on Facebook. This is how I can continue to grow the show and expand the reach, and I truly appreciate your support. All right, guys, so next week, what do we got next week? We got another general Q&A. So guys, send me those questions. Those of you on my texting service, you can send me them that way, or you can send it to me at my email, kosi@kositalks.com. All right, guys, with that being said, I will bid you good night, and I will see you next week, same bat time.